I'm here at the 2007 meeting of the American Society of Clinical Oncology. Later today I will be presenting the results of a randomized ECOG trial that compared lenalidomide and high-dose dexamethasone versus lenalidomide and low-dose dexamethasone in newly diagnosed multiple myeloma. This Eastern Cooperative Oncology Group study was funded by the National Cancer Institute. It compared lenalidomide, which is also called Revlimid, plus either high-dose dexamethasone or low-dose dexamethasone. We accrued a total of 445 patients, and we analyzed patients by toxicity and survival. This study had a primary endpoint of response rate between the two arms at 4 months. The study was being monitored by an independent data monitoring committee. At the first interim analysis, the data monitoring committee found a significant difference in overall survival between the two arms, and therefore the study was halted. In essence, the study found that the overall survival was significantly better in patients receiving lenalidomide plus low-dose dexamethasone compared to lenalidomide and high-dose dexamethasone. Patients receiving lenalidomide plus low-dose dexamethasone had a 1-year survival rate of 96% compared to 87% for patients receiving lenalidomide and high-dose dexamethasone. So therefore, we actually found that by lowering the dose of steroids rather than losing efficacy, we actually improved survival. The study also found that there were other advantages to the low-dose dexamethasone regimen. Many of the side effects, the serious side effects such as deep vein thrombosis, infections, pneumonias, fatigue, and others were lower with low-dose dexamethasone as expected. Deep vein thrombosis is blood clots, and they occurred in over 20% of patients receiving the lenalidomide and high-dose dexamethasone, and under 10% of patients receiving lenalidomide and low-dose dexamethasone. So this is a major finding both in terms of the survival and toxicity differences in terms of this trial, demonstrating the superiority of low-dose dexamethasone plus lenalidomide over the high-dose dexamethasone plus lenalidomide regimen. I think beyond that, the study has implications for the use of high-dose dexamethasone in general for patients with newly diagnosed myeloma, even for other regimens. I believe that the study establishes that there may be no significant advantage to doing that. In fact, that patients may have better outcome by choosing the lower dose dexamethasone regimens. We believe the lenalidomide and low-dose dexamethasone regimen has produced some of the best 1-year survival rates. It remains to be seen over the next few years how this plays out. In clinical practice, when using either lenalidomide and dexamethasone or thalidomide and dexamethasone for that matter, deep vein thrombosis or blood clots is a serious issue. By using a lower dose of dexamethasone, the deep vein thrombosis risk is lower to the point where aspirin alone can be used as a prophylactic regimen, and we do recommend that in all patients. However, if high-dose dexamethasone is used, then you would need more intense anticoagulation. This trial will continue to be analyzed, and I hope in the next several months we'll be able to present results on response rate and time to progression. We also hope that the results of this trial will be used in developing the successor trial, where the Revlimid or the lenalidomide low-dose dexamethasone regimen is used as the standard arm, and we try and improve on that.